All right, the next thing to finish up in this section is a discussion on pleural effusions. And pleural effusions, one of the things that I want to sort of show you before we get started into this is what exactly does a pleura do? Okay, there's two surfaces to the pleura. Okay, normally the one portion of it is tacked up against the chest wall itself. Okay, so that's right up against the chest wall. This is the chest with the ribs running through it. Okay, so the pleura is right against that. Okay, so that's one lining. And then there's another lining, and you look at it from the lung standpoint. Here's the lung coming in. Okay, it has another lining here that's right against the actual lung itself. Okay, so the lung is inside here. This distance between the green and the red line is very small. Okay, it's usually less than a millimeter in distance. Okay, so they're almost touching, but they're not quite touching. There's actually fluid in between that. Okay, that fluid acts like a lubricant. Okay, and it allows the two pleuras to rub up, not really rub against each other. It basically just slides against each other. Okay. Under normal circumstances, that fluid is around 25 cc's per each side of your chest. So it accounts for a very, very, very small volume in there. But it's actually a very important lubricant. Okay? You can get disease processes where this area, for some reason, becomes sensitive to like an inflammatory reaction. And then you begin to get accumulation of fluid in here. And it begins to separate out the lung from the actual thoracic pleura. Okay, and that's what we call a pleural effusion. When you look at a pleural effusion, there's two kinds of pleural effusion. There's an exudative and a transudative. Okay? The transudative is the one that's actually more benign. It's an inflammatory mediated reaction, or it could be due to a patient that is developing congestive heart failure. Mostly the transudate is basically like, but not like white plasma. It's more like interstitial fluid. Okay, so it doesn't have very much protein in it. So it transudates. It transudes through the cell, the membrane. Okay, but it doesn't usually have a lot of protein in it. Okay, when you look at it, it looks just like interstitial fluid does. Interstitial fluid has a sort of like very tea-like color. Okay? And so it's got a water content, okay? And it tends to have a lot of lactic dehydrogenase in it as well. Okay, but the protein content overall is low for transudate. Exudative processes, on the other hand, are much more serious. And the reason exudative processes are much more serious is because it's telling you that you're having a destruction of the actual capillary interstitial interspace. In this case, it's a capillary to the pleural interspace. Okay, so you get a disruption of it. So you can see red blood cells inside the. Sometimes you'll see the exudative will be bloody in appearance. The other thing you'll see it has a very high protein content as well. So when you actually take the fluid and agitate it, it'll form micelles, okay, and then you'll see that the protein drops out of solution. That's a bad sign because that's either an infection or cancer. If you see blood coming out and it's not due to trauma, it usually means cancer. Okay, so that's something you don't want to see. Okay, so chest tubes, and you put in somebody with as exudates, it's got a pleural effusion and it comes back straw-colored. That usually can be something benign that can be treated. But if it seems hemorrhagic, then it's more likely to be cancer. Okay. The other thing that pleural effusions can be caused by can have different kinds of sources. Sometimes they're due to infections. Okay, those are called what's called a pyothorax or an empyema. And that's usually from an open chest wound where you got a lot of dirt came into the patient, and now they got an infection in there. It's going to be pretty nasty. Or you can put a chest tube in without adequate sterile field, and you can get an infection inside, which you get an empyema, which is very difficult to treat. So you don't want to really get yourself into that situation. This is what you see normally in a chest x-ray. You see that the pleural effusion will lay out, okay? And you want to put the chest tube in posteriorly to drain that properly. Unfortunately, if it's an empyema, many times you get fibroblast deposition as well, and you start forming septa that form inside, and you're not able to drain all this liquid out. If you have a hemothorax, it's called, of course, it's hemorrhaging into the pleural space. And if you see a chylothorax, it's because you've damaged the thoracic duct, and now the lymphatics are unable to empty out this area. If you put a chest tube in a person with chylothorax, it'll become obvious. It looks like milk coming out of this person's chest. Okay? And it isn't milk, and it's not propofol. Okay? So make sure that if you have that, most likely that's going to be on this side. Why on that side? Because the thoracic duct goes here. So it's more likely that you would put in a central line on this side and you damaged it. Okay. If this becomes a prolonged problem, it can develop thickening, okay? And you can develop cancers of this as well, called mesothelioma. A typical example of mesothelioma is due to asbestosis exposure. Okay? What asbestos is basically a glass fiber. Okay? It comes out and you inhale it, and what happens at that point is that it'll bore through the actual wall of the lung until it gets all the way into the pleural space. And now once the glass fibers are in there, it's very difficult for the body to get rid of it. The body's been trying to get rid of it for weeks or not months or several years, but it can't. Every time the macrophage gets around it, it just gets skewered by this glass fiber. So it can't get rid of it because it's inert. Okay? So what happens is the reaction is the body tries to sort of grow over it. And unfortunately in that process, many times the cells that are very highly regulated become disjointed and begin to overgrow at too fast a speed, which is what cancer is. It's cell growth that's unregulated. Okay? And eventually what ends up happening is you get a restrictive disease pattern where the lung it can no longer expand because of the pleural thickening. Okay? Not a good thing. The other thing that can also be considered a restrictive disease are things that are diseases of the chest wall. Things like scoliosis can eventually lead to significant restrictive disease impairment. You can also have diseases like ankylosing spondylitis, where you get fusion of the thoracic cage, and this will limit the person's inspiratory effort. Okay? It also can be a significant problem. Neuromuscular diseases can also affect and become restrictive. Things like poliomyelitis, where you're the alpha motor neuron affecting the control mechanisms. In this case, it would be the C3 through C5, C3, C4, C5, which would be the phrenic nerve, could be diseased from the polio. You can also have ascending paralysis, which is Guillain-Barré, where you get a demyelinated disease, usually going from lower extremities upwards. Sometimes Guillain-Barré will do it the other way, but most of the time it's ascending paralysis. You may also have Lou Gehrig's disease, which is ALS, which is amyotrophic lateral sclerosis, where you also get destruction of the lateral components. And then you have myasthenia gravis, where you don't have enough but you don't have enough acetylcholine receptors because they're destroyed by immune reaction. And then you may actually have muscular dystrophies with the destruction of the muscle themselves. Either one of these will eventually cause a significant stiffening of the chest wall, and the person is not able to use their diaphragm effectively. And that's it on that section.